Hi, today I want to go over a case we recently did utilizing the transcaval access to deliver the aortic valve during transcatheter aortic valve replacement. Majority of the aortic valves are delivered through the femoral access during transcatheter aortic valve replacement. In less than 5% of cases, the lower extremity vessels are either too diseased or too small for delivery of the valve. In these cases, other access modalities are utilized, such as the subclavian or carotid arteries, or direct aortic access, or transapical. The case we're talking about today is utilizing transcaval access, whereby the sheath is placed through the aorta via the inferior vena cava for the delivery of the valve. These are the patient's characteristics. He's a 75-year-old gentleman, significantly symptomatic, with mildly decreased ejection fraction, who also has atrial fibrillation. He did have significant gradient across his aortic valve and a valve that was almost getting into critical values. This is his CT scan. It is somewhat hard to see, but he does have significant bilateral disease involving both femoral access sites. Of note, also his subclavians were significantly diseased, so we had to think of alternative access in him, and that's why we chose to go transcavally. This is his transcaval workup. It was noted that the aorta was least diseased in the middle of L3, and that's where we decided to cross over from vena cava into the aorta. Area measured to be at 485 millimeter square, therefore suitable for deployment of a number 26 millimeter Edwards S3 valve. This is the aorta-vena cava angiogram at the beginning of the case. We usually do not perform an angiogram, but for the sake of this presentation, we did proceed to do so. These pictures show how we define the crossing angle by using two pigtails in orthogonal views. Usually we determine this from the CT beforehand as well, but I always do it at the time of the procedure as well, because I want to make sure that the CT is correct, and it almost always is. Here we are already situated for the crossing. We do have a JR4 with a number 20 loop snare in the aorta and a Astado wire in a piggyback and a microcatheter, namely Navicross, in an IMA catheter in the vena cava. We are going to check to make sure we have the right angle in the orthogonal views that we already have measured from before. And once we're satisfied, we will cross. As you can see in the orthogonal view, the catheter is looking toward the middle of the snare, and our angle is appropriate at this point to proceed with electrocautery. Here, electrocautery has been performed. The wire has entered the aorta through the snare. Snare is tightened, and the wire is brought into the catheter. This is the continuation of the previous slide, whereby the wire is pulled into the catheter placed in the aorta. It is very important, once the wire is snared into the JR catheter, that somebody advances the wire at the same time as the other person advances the JR4 catheter, in order to avoid the laceration of the aortic wall. Once the wire is in the aortic arch, the piggyback is advanced over the wire, and the microcatheter over the piggyback. Once the microcatheter is in descending aorta, the wire is released from the snare and withdrawn. And now the stiff wire, in this case the Lunderquist, is advanced through the microcatheter into the descending aorta. The microcatheter is withdrawn and our delivery sheath, in this case number 14, Edwards E sheath, is advanced from the vena cava into the aorta over the Lunderquist wire. Now we're going to proceed with deployment of the valve as we usually do in normal access transcatheter valve replacement by placing a pigtail in the aortic root and doing an angiogram to define our deployment angle. As you can see, also a temporary pacemaker has been placed into the right ventricle from our venous access site. Here's the deployment of our valve, number 26, Edwards S3 valve. This is our angiography after deployment of the valve. As noted, there is no significant peripheral leak, which was also confirmed by echocardiography, as well as by hemodynamics. There was good separation between the left ventricle and diastolic pressure and the aortic diastolic pressure, and no significant gradient between the left ventricle and aorta, and therefore the result was acceptable, and we went through the last stage of the procedure, which would be the closure of the aortic site of entry for the Edwards sheath. Here, the delivery system for the valve has already been removed, and we do advance a coronary wire through the sheath for safety purposes, just in case something is wrong during the closure, where we have access to get back into the aorta. We then advance, in this case, an 8x6 Amplatzer Duct Occluder device through an edgeless catheter into the aorta and get ready for the closure. In most of the cases on 14 and 16 French sheaths, the aorta can be closed by 8x6 Amplatzer occluder device. If the sheath has remained in the aorta overnight or for multiple days, which sometimes is the case where there's hemodynamic support needed via transcaval access, you do need to use bigger Amplatzer duct occluder devices. But for majority of what is Tavr, 8x6 would do. Here the Edwards E sheath has been withdrawn back into the vena cava, and it is important that the sheath is pulled back all the way into the vena cava, not halfway, to prevent any extravasation of blood into retroperitoneum. The Achilles is then maneuvered so to line the ductal occluder device with the aorta. The whole system is then pulled back so that the ductal occluder disc is against the aortic wall. The result of the closure is satisfactory with no evidence of extravasation into the retroperitoneum. Therefore, the ductal occluder device is released. And this is our final angiogram showing no extravasation of the dye into the retroperitoneum. This slide shows the withdrawal of the coronary wire before sheaths are removed and hemostasis is achieved using closure device. This patient did very well. He was able to sit in a chair a few hours after the procedure, ambulated later that day, and was home in 48 hours. In our experience now, having performed many transcaval cases, patients do very well and mobilize very fast, and barring any complications that you normally potentially have with transcatheter valve replacement, their post-procedure care is fairly straightforward. Thank you.